Hello, everyone. This is Greg Moody in the Governor's Office of Health Transformation. Thank you for joining us for a conversation about early entry into Ohio's comprehensive primary care program. We are hoping that beginning in January 2017, everyone on this call will get access to enhanced Medicaid payments for comprehensive primary care. For doing those extra activities that we know many of you are doing already, we think it is time that our program reward that with better reimbursement. How to do that is the purpose of this webinar. We know many of you are also applying for the Medicare version of this, the Comprehensive Primary Care Plus program. That selection process, the application for that was due September 15. We didn't want to confuse the two programs, so we waited until after that application process was completed. But now we wanted to pick up and describe our program in some detail, let you know how to get enrolled. So hopefully beginning January, those of you who want access to both Medicaid and Medicare enhanced rates will have that. I'm going to turn the discussion over to Karin Hoyt to walk us through a description of the program, and then we will be able to take questions throughout. You have a chat feature on the webinar. If you submit your questions that way as we go along, we will then try to get to as many questions as possible within the hour we have allotted for the webinar. So again, welcome. We're glad you're interested. Joining us on the call, Karin.
Thank you very much. To start off, here are a couple of notes about the Ohio CPC program. It's a part of our larger payment innovation efforts in Ohio. This is an effort championed by Governor Kasich to create an unprecedented opportunity to better reward primary care practices that provide Ohioans the quality of care they need to increase their level of health at every stage of life. Today we'll be providing an overview of the Ohio CPC program, as we've mentioned. I'd also just like to point out for a moment here that there are additional details about Ohio CPC that can be found at the Ohio Department of Medicaid website listed here. You can see a few bulleted statements about the types of information on the website. We have 5 objectives for today's webinar. First, how this fits within the context of Ohio's approach to pay for value instead of volume, which practices are eligible, what requirements must be met, how payment will change for the Ohio CPC practices, and lastly, how this compares to and complements Medicare's CPC Plus program. Here you see a continuum of healthcare arrangements. To the far left, you'll note that we have our traditional fee-for-service program, where there's no tie necessarily to quality and services provided. As part of our larger payment innovation efforts, Ohio is focused on primary care practitioners being rewarded for their success as patient-centered medical homes, which also complements the existing episode-based payment model targeted primarily to specialists and provides enhanced payments for specific episodes of care. You'll see those 2 areas highlighted in green on this particular page. And here's just a brief snapshot of our governance structure for the larger payment innovation efforts, including the Governor's Advisory Council on Healthcare Payment Innovation. You'll note that we're focused on the blue highlighted portion today for the Ohio CPC discussion. Of note, Ohio CPC was designed with the help of over 800 stakeholders, from clinicians to practice office managers to representatives of Ohio's managed care plans. As you know, Ohio's been developing a model designed to improve primary care. One key feature of the model is that it is inclusive. Every Medicaid member will be assigned to a provider. A couple of additional notes about Ohio CPC. It financially rewards primary care practices that keep people well and hold down costs. There is one program that all practices participate in. We recognize that in Ohio, we have practices at varying levels of adoption of PCMH principles. After this first early entry year, when we do have some parameters around participation, the program is designed to encourage all practices to participate. It's inclusive. We're attributing all Medicaid lives to a provider, as I've mentioned. All providers will have to apply to meet specific enrollment requirements, which we'll discuss in more detail in a moment. As mentioned, we'll launch the early entry version of the model in January 2017, and then the model will be open to all eligible practices in January 2018. These are our payer partners we've been working with along the way. Both commercial and managed Medicaid plans are participating, and these plans collectively cover nearly 90% of Ohio's population, about 10 million covered lives. Commercial plans may choose to implement comprehensive primary care with variations from the Medicaid model, but all Medicaid managed care plans will participate in the unified model designed by ODM and being described here today. Next, we'll move along and review which plans are eligible to participate in Ohio's CPC program. You'll see here a list of eligible provider types and specialties. We've focused on specifically practitioners who are practicing primary care and have limited the list of eligible providers to those listed here. In order to participate, a provider must be listed as one of these provider types, based on how that provider described themselves when they enrolled with the Medicaid program. Individual providers must have one of the eligible specialties listed on the right, which may have been declared to ODM or a plan for their official records. And for those who have also been following the CPC Plus program from CMS, I'll note that for Ohio CPC, we're including FQHCs and pediatric practices. That is one difference from CPC Plus. Neither of those are included in that program. And here we have a review of the specific eligibility requirements for practices to participate in calendar year 17. First, practices must have an eligible provider and specialty type that we just reviewed. Additionally, a practice must have either 5,000 or more attributed Medicaid individuals and national accreditation, 500 or more attributed Medicaid individuals determined through the attribution with claims, and an NCQA Level 3 accreditation, or 500 or more attributed Medicaid lives and be enrolled in the Medicare CPC Plus program. Additionally, you'll note that we're asking all participating CPC Plus practices to commit to a few things. For example, sharing data with payers and the state, participating in learning activities, and meeting activity requirements within 6 months. And unlike some other programs you may be familiar with, things like electronic health records are not required for Ohio CPC. And here you'll see our timeline for early enrollment in this process. In September, we have identified practices that meet early entry criteria, and we've invited folks who are on this webinar today to enroll in Ohio CPC. Next, as today, we are hosting our webinar for those invited practices, and we thank you for joining us. Between September 28th and October 31st, Ohio Medicaid will provide an online link to invited practices to enroll. To be very clear, we'll be providing the links to eligible practices ahead of September 28th. Enrollment will begin to be open for practices on September 28th. It will close on October 31st. You may note that this is a little bit different from communication we've had in the past, but we are able to open enrollment a few days early, and we thought it would be best to do so. And late in the calendar year, we'll invite practices selected for CPC Plus that also have 500 or more Medicaid members to enroll. And beginning in 2017, on January 1st, the performance period begins for practices enrolled in Ohio CPC. And here you see a screenshot of our enrollment process webpage. Early enrollment in Ohio CPC is a simple online form where practices fill out basic practice information, which PCMH accreditations they have, where they have applied to CPC Plus, and attest to meeting the requirements of the program, which include participation in learning activities, sharing data, and meeting the activity requirements. One note for the enrollment process, For those who have received invitations from Director McCarthy, we have also included for you the eligible Medicaid provider IDs. We ask when enrolling in the program that you enroll for those practices associated with primary care activities, and if perhaps you have more than one provider ID that was eligible and listed in your letter, you enroll for each of those provider IDs separately. And in 2018 and beyond, practices will no longer be required to have existing PCMH accreditation to enroll. So in looking at the differences between this early entry group and those that will begin January 1st, 2018, that is perhaps the most notable difference. You'll also note that we continue to have a commitment requirement around sharing data, learning activities, and meeting the activity requirements within 6 months. Next, we'll discuss requirements that practices must meet once they've enrolled in the program. The Ohio PCMH model has 3 enhanced payment streams for primary care practices and 3 categories of requirements. Here you see listed, there are 8 activity requirements, which include things like 24/7 access and risk stratification for your patients. There are 5 efficiency measures, such as ER visits per 1,000 members, and 20 clinical quality metrics. This is significant that we got all of the payers to align on one core set of measures tied to a payment. In a moment, we'll dig into these requirements a little bit more in detail. A note here that practices must meet these requirements in order to get access to the 2 payment streams. First, an additional per member per month payment, which compensates practices and supports them for activities that we believe improve care. Secondly, there's a shared savings payment to reward practices for lowering total cost of care while still meeting quality, efficiency, and activity requirements. And here we have the full list of Ohio CPC activity requirements. As I mentioned previously, there are 8 having to do with same-day appointments, 24/7 access to care. We have risk stratification of patients, population health management, team-based managed care, follow-up after hospital discharge, tracking tests and specialist referrals, and collecting information on patient experience and acting on the results. When you enroll in the Ohio CPC program, you will be attesting to meeting the startup requirements in these categories within 6 months. And here we have listed the 4 main efficiency requirements, of which providers must pass 50% in order to achieve this shared savings payment. A 5th efficiency metric you see listed here will be reported on, but will not be tied to payments. That's highlighted in the lighter blue and is titled Episode-Related Metric. Here you see the listing of 20 quality requirements. They're further divided into 4 different population groups, and practices will have to pass 50% of the requirements that are applicable to the practice. You'll see noted here we have pediatric health measures, women's health measures, adult health, and behavioral health measures as well. We anticipate that practices will meet the minimum denominator for some clinical requirements, but possibly not others. For example, pediatric practices are less likely to have enough members to be measured for women's health practices, but the pediatric health metrics should apply to them. Next, we'll move on to cover what the payments are that are available to practices enrolled in CPC. As I described a moment ago, practices that meet the requirements for early entry are eligible for per member per month payments and shared savings payments starting in January 2017. PMPM payments will continue as long as requirements continue to be met, and some practices will be eligible for shared savings payments. Next, we'll go into detail about each of these payment streams. There will be no practice transformation support for practices enrolled in 2017, as the early entry practices are already relatively advanced in their journey. Practices and managed care plans will receive per member per month payments prospectively and quarterly. The PMPM payment for a given CPC practice is calculated by multiplying the number of members attributed to the practice in each risk tier by the per member per month value for each risk tier. The risk tier of each member will be updated quarterly as new claims are added to their history. And you'll see here the breakdown of the risk tier categories we're using. I'll note that we're using the 3MCRG risk tool in order to tier. You see there are $1, $8, and $22 tiers for the risk stratification. Shared savings payments will be made to practices retrospectively, and they're based on their total cost of care. Activity requirements and quality and efficiency requirements must be met to receive both PMPM and shared savings payments. There are two types of shared savings payments that are available, and you see them listed here. The first is based on self-improvement. If you lower costs based on your own practice's baseline, you'll be eligible for this payment stream. The second is an overall low cost. That is, the 10% of practices at the end of the performance period with the lowest average risk-adjusted total cost of care will receive this payment whether or not they have lowered cost of care over their own baseline. Practices may receive either or both of these shared savings payments. In order to determine the total cost of care of your attributed patient panel, all of the claims and encounter costs are added along with per member per month payments made to the practice, with some exceptions. Patient exclusions include dual eligible patients, members with limited benefits, and all other members with third-party liability coverage. Service exclusions include all waiver spend on underutilized services such as dental, vision, or transportation, as well as spend for members with a NICU stay with more than 90 consecutive days in long-term care and outliers within each risk band. These exclusions were designed to keep the model as inclusive as possible while still being fair to CPC practices. For example, spend on infants in the NICU is widely variable, out of the control of the infant's PCP, and difficult to risk adjust since they have very short claims history. Finally, let's review how Ohio CPC compares to the Medicare CPC Plus program. I'd like to emphasize that Ohio's CPC program complements, but does not exactly copy, Medicare's CPC Plus program. We believe CPC Plus complements the work we've done already to date in Ohio. Our care delivery model is based on similar principles to those in CPC Plus, and our payment streams and requirements are also highly aligned. There are a few differences that I want to mention today. For example, we define practices, as I've mentioned, based on Medicaid provider ID used for billing, and CPC Plus is based on individual practice sites. Our incentive payment is shared savings rather than a pay-for-performance bonus as is proposed in CPC Plus. CPC Plus includes partial capitation in Track 2, and in the Ohio CPC program, our alternative to fee-for-service ties to the episode-based payment work already underway. As a quick aside, we currently have performance reports going to the specialists primarily responsible for 13 of our episode-based payments. We plan to design 30 more episodes that are underway this year. And the goal is to convert that information into reports for primary care practices. One last difference between our model and CPC Plus, our quality metrics include pediatrics and several other measures that are not directly related to Medicare, so they are not included in CPC Plus. There's one last comparison we want to make between Ohio's approach and CPC Plus, and that's the proposed reimbursement. Ohio and Medicare are highly aligned on the activities we're willing to support with enhanced revenue, but our specific approach to reimbursement is a bit different. and that's allowed by CPC Plus. You'll notice that the Ohio Medicaid fee-for-service and Ohio Medicaid managed care payments are identical. Director McCarthy sets these reimbursement levels for the plan. Medicare fee-for-service has a lower panel size requirement and higher per member per month payments. And as mentioned before, the payment stream design is slightly different. CPC Plus has pay for performance rather than shared savings and includes partial capitation in Track 2. The column for commercial and Medicare Advantage is blank because these decisions are all made at the individual plan level. And here we'll end with a high-level timeline for the CPC Plus application process. Applications were due September 15th. CMS will select CPC Plus practices by the end of the year for payment starting in January 2017. That's also when we'll launch our early entry into the Ohio CPC model. A reminder to folks as we close that applications for Ohio CPC will be due October 31st, and we will be following up within the next week with additional information about the specific location for enrollment and any questions that you may have after the website. With this, we'll move into questions that may have come in during this webinar.
Thanks, Karen. We'll open it up to questions. As a reminder, there is a chat feature on today's webinar. If you have a question, feel free to type it into the chat box and we will try to address it on today's call. A lot of the questions that we are seeing come through are related to how we are identifying or defining a practice for the purposes of Ohio Medicaid. So just to be really, just to clarify, for the purposes of Ohio's comprehensive primary care model, we are identifying a practice at the Medicaid billing ID level. This is a 7-digit number that you would register with the Ohio Department of Medicaid, through which you send your claims into Medicaid. This is different from the Medicare CPC Plus, which is at the bricks and mortar site level. So you will need to identify what your Medicaid billing ID number is. If you received an invitation from Director McCarthy, we actually identified that number for you. So that number is embedded into the invitation that you received. The next question we have is, we have multiple primary care practices under our Medicare ID. Many are NCQA PCMH level 3, but some are in the process of meeting the NCQA PCMH requirements. Can we apply for early entry for all practices under our Medicaid ID with many, but not all, PCMH level 3 recognition? Just to be clear, I'm assuming you mean Medicaid ID versus Medicare. And we are looking for NCQA 3 accreditation at the billing ID level. So whatever that looks like in your practice, ensuring that it aligns with whatever your Medicaid billing ID is and how NCQA is recognizing that particular location. Next question. For those practices that have already applied for CPC Plus, will the application apply to Ohio CPC, or will another application need to be submitted? We are asking those who applied for CPC Plus to still submit an application. If you have received an invitation from Director McCarthy and Department of Medicaid to apply, it is because we believe you might meet the early criteria enrollment already without the CPC Plus program participation. If you do not already have the accreditation that's required for the early entry and would need the CPC Plus participation to participate in the Ohio CPC model, that information will not be available to us until December, and we would be comparing lists once that list is released from CMS with the list that we have for Ohio CPC to see who might be also eligible to participate in the Ohio CPC model.
So just to clarify, everybody on this call is eligible to apply to enroll in Ohio CPC. By the end of the year, we'll see who is selected for CPC Plus, and we'll invite them to join as well.
Next question, are you able to apply if currently participating in an ACO? There is nothing that would limit you from participating in Ohio's CPC model if you are participating in an ACO. The simple answer there is yes. Next question. In some of the materials, I have seen the term negative incentive payment regarding payment. Can you explain what is the downside risk for providers? For Ohio CPC model, we actually do not have downside risk. What I think you might be looking at when you're seeing a wording around negative incentive payments might actually be related to our episode-based payment model, which is a separate model from the Ohio Comprehensive Primary Care model. There's also information about episode-based payments on the Ohio Medicaid website, and I believe there's a link called episode-based payments. And there's a great deal of information there, as well as the Ohio Office of Health Transformation's website.
Yeah, and this is an important feature of the Ohio CPC program. It is voluntary to participate in. Our logic is that our current fee-for-service program doesn't actually pay you for those activities we know keep people well and hold down the total cost of care. So for those of you who have made investments to conduct those activities, we think we should get enhanced reimbursement to you. So it is all upside, not downside, and voluntary to participate.
Next question. If you don't sign up for early adoption, when could PMPM payments begin? So in early enrollment, so the enrollment period that we are talking to you about today is for January 1, 2017 through December 31st, 2017. If you elect not to participate in this early round, the next enrollment period will be for participation in 2018. So if you opt not to participate until the next round, that would not be until January 2018.
And this is a difference also between the Ohio CPC program and the Medicare CPC Plus program. The way CPC Plus is working, there is a one-time selection process, and the practice is selected into CPC Plus. That will be a 5-year demonstration. In the Ohio CPC program, once we open enrollment January 1, 18 for all practices, practices can come into the program at any point on a regular schedule, likely quarterly, but it's an open process. It is not a single moment of selection that has been closed into the future.
Next question. Will the PMPM come from the Medicaid managed care plans or from the Ohio Department of Medicaid?
Per member per month payments will, for the Medicaid fee-for-service population, come from the Ohio Department of Medicaid. PMPM for the managed care population will come from each of the managed care plans.
Next question, when will practices get baseline data and target goals? What if baseline data is already above target and stays there? Will we measure on improvement or on performance or both? So we hope to get you some initial sets of information before the beginning of the performance period, January of 2017. And we will also be providing to you quarterly reports starting in the first quarter of 2017, which will also be providing baseline information for you on historical data based on the members that are attributed to you through the model. And then attribution will be done on a quarterly basis, and going forward, your quarterly reports will be updated on more current data based on as your attribution continues to also update. Next question, we have a number of practices across the practices. We have in aggregate far more than the requirements. Can we apply as practice partnerships? For the early entry year, 2017, we will not be electing to go the route of practice partnerships. This is something we had talked about early on, and there is a great deal of discussion that we need to continue to have around practice partnerships, and so we will not be offering this version of participation until 2018. Oh, and we just got the question, can you further explain practice partnerships? This would be, Director Moody.
Yeah, I'll jump in here. So really the issue with practice partnerships is this issue of scale. To be able to calculate performance bonuses, for that to be actuarially sound, you have to have a certain number of covered lives in a practice. And our rule of thumb to date has been that needs to be about 5,000 lives. However, we did not want to exclude small practices from ever being eligible to receive a performance bonus. So by January 1, 2018, our plan is to have in place a pooling mechanism so small practices can join together to reach the scale necessary to be eligible for a performance bonus. However, we did not feel we could get that pooling mechanism in place by January 1, 2017, and we didn't want to delay the start of the program an entire year. So that's why you see in the early entry cohort a focus on large practices of 5,000 or more that are accredited, because that lets us reach the scale necessary to flow those performance bonuses. So that's why we are moving ahead with practices of scale in 17, because we wanted to get the money flowing. By January 1, 2018, we will have an aggregation process in place that is clear, so practices of any scale can partner up and become eligible for the performance bonuses.
Next question we have is, please clarify, are 500 Medicaid patients required per brick and mortar building or across an entire practice? So this gets back to how we are defining a practice for Ohio CPC. It would need to be 500 Medicaid members at the billing ID level. And again, that is how, that is the 7-digit number that was provided in the invitation letter from Director McCarthy.
This is Greg Moody again. One of the reasons also to start the program with a smaller cohort of sophisticated practices is to address issues of administrative efficiency in the program. So for example, as a simple starting point, for Medicaid, it was obvious to choose Medicaid billing ID as the administrative link to practices. However, one of the things we expect you to tell us during this first year of 2017 as we look for ways to make this administratively more efficient, is that the right criteria to use, or should it be something else? CPC Plus chose the site level. That is problematic for Medicaid as an issue of scale. The Medicaid billing ID is convenient for us, but we recognized as we started looking at how practices are organized, some have all of their sites organized under a single billing ID, but others have multiple sites under multiple billing IDs. So through the course of 2017, we will have to agree together what seems to be the most efficient. So then as we expand the program to others in January 2018, it's as clear and simple as possible.
The next question, if you participate in an ACO, are you eligible for both PMPM and shared savings? And again, the answer to this would be yes. There's no limitation to your ability to receive PMPM, and the limitation on shared savings is simply the 5,000 Medicaid lives. Next question is, if accepted in Ohio CPC as an early entry, when will the first PMPM payments be received? We intend to ensure payments received on a quarterly basis. We believe we would like to start those by January 2017. Next question, we are trying to calculate a budget for 2017. Realistically, for the average pediatric practice with 3 to 4% complex care children, what would the average PMPM be? So through the calculations, and I believe Karen hit this, and I don't remember what slide it was, but we have calculated the average PMPM for a practice would be around $4.
And back on the resource slide, one thing I would point out is that all of the methodology to make these calculations is on the Medicaid provider website. And I think the answer to that is going to vary significantly at the practice level. For example, it's going to tie back to what portion of your panel is in the various tiers and how that translates into an overall potential PMPM payment. So even though when we look at our data across all practices, we think the average PMPM is going to be in the range of $4, the actual tiers are spending at $1, $8, and $22. So depending on the mix of your panel, that is going to be the answer to the question of how to budget. And again, we tried to be as transparent as possible in putting details of the methodology on the website, so as best as possible, you'll be able to calculate that for your own practice.
Next question, please clarify, will PMPM payments also be available to commercial lives managed by PCPs? This is a multi-payer initiative where we have both the Medicaid managed care plans participating as well as the commercial plans who have been helping us develop the model all along the way. The commercial participation has been voluntary, but they have sat with us at the table for the past few years for full development of the primary care model. And it is promising that each of those commercial payers have all applied for also the Medicare CPC Plus model. And we have been talking and working with them to also commit in some way to participate in the Ohio CPC model by 2018?
And I would answer that question like this. For each of you, Anthem, Aetna, United, Medical Mutual, CareSource, Molina, Paramount, AltCare, Summa, Gateway have all indicated that they will pay enhanced rates because they are applied to participate with CPC Plus. So if you have not yet entered into a discussion with them about how your contract with them is going to change to take advantage of those enhanced rates, I would encourage you to reach out to each of those plans because they have made a commitment to participate.
Next question. Are there any new software or hardware requirements necessary for data mining, or is all information just generated from claims data? At this point in time, we are generating the information needed through the claims data. There are no software or hardware requirements to participate. The next question is, will practices have to bill for the PMPM payment, or will it be automatically calculated by Medicaid? The PMPM payments will be calculated by the Department of Medicaid. There will be no need for practices to do any calculations on their end for the purposes of the PMPM. Next question is, how soon will we get our attribution list as we move into January 2017? Great question. We would like to get these attribution lists out as soon as possible. The enrollment period ends October 31st, and we'll go through a review process and hope to get an attribution list to you by the end of the year, 2016.
Which will then refresh on a quarterly basis.
Next question, does this apply to Medicaid primary only? How does Medicaid secondary play in? I'm assuming this question is related to whether someone's coverage is Medicaid as their primary coverage. So this is limited to those beneficiaries whose Medicaid coverage is the primary source of coverage here.
As we're looking for the next question, I'll mention too that all of the questions we will organize into a frequently asked questions document that already exists on the Medicaid provider website. And as we get additional questions, we'll try to refresh that periodically just to make sure everybody has access to answers to the various questions.
Okay, thank you for the questions today. A lot of good questions. This webinar is being recorded, so we will post this to the Office of Health Transformation website by the end of the week.
Thank you all for participating. We have a real opportunity ahead of us here to finally, after I think a decade of primary care rates not keeping up with the value of those services, to really reset the system in a way that rewards you for investments you've already made to keep people well and hold down the total cost of care. So we appreciate that you are possibly willing to enter into this experiment with us. We think because of what you've done already, you are the ideal partners for us. So we hope beginning September 28th through the end of October, you choose to enroll, and we look forward to starting the partnership then in January 2017. Do take a look at that Medicaid provider website. There is a lot on there, and we will refresh it with the questions that you all asked in this webinar. Thank you for your time. I think we're adjourned.